Welcome to the webinar, Overview of Child Passenger Safety for Maternal Child Health Nurses and How to Conduct the Car Seat Tolerance Screen. This presentation is brought to you from the Child Passenger Safety and Occupant Protection Healthcare Project, which is under the Maryland Institute of Emergency Medical Services Systems. This project is produced with grant funding from the Maryland Highway Safety Office. I am Susanna Gaitis Jones, and I coordinate the Child Passenger Safety and Occupant Protection Project at MIMS. We also have two other speakers today that I will introduce briefly now, and you'll hear from in a little bit. Julie Sejak, who is a nurse at Upper Chesapeake Health, and Joan Geckel, who coordinates patient education for Mount Washington Pediatric Hospital. The goals of this presentation are to teach about child safety seats and how they work to protect children, to state Maryland's child passenger safety laws, to explain some liability limits of what nurses can do in child passenger safety or CPS, to talk about the essentials of what you would need to know in your job in the hospital working with newborns and their caregivers, and to teach key messages that you can share with parents. Also, we're going to talk about conducting the car seat tolerance screen and the basics in the steps involved in administering that test and how to make that test more valid. I want to give a special thanks to Michelle Spencer and the Special Care Nursery at MarylandEMS Medical Center who helped with a lot of the photos for this presentation. So why is child passenger safety important? As this article shows, children die in motor vehicle crashes. This is from 2019. Very, very sad. Motor vehicle crashes continue to be a leading cause of unintentional injury and death for children. The good news is that the numbers of children dying have gone way down over the last 20 years, thanks to many different things that I'll talk about in a little bit. But any death is unacceptable. So let's talk more about the numbers first before we can talk about what we do to prevent this. In the US in 2019, about 646 children died as passengers in motor vehicle crashes. Over 6,000 were hospitalized, and pushing 100,000 children went to the ED for care after a crash. On average, every 30 seconds, there is a crash involving a child under the age of 13, and on average, 2 children a day are killed while riding in a passenger cars. And then another 14% of children in crashes are injured. And why is this such a huge problem? What else contributes to make this a big problem? Well, where we know if restraints were used, like car seats or seat belts, more than a third of the children who were killed were not restrained in car seats, boosters, or seat belts. More than a third. And we know that the proportion of those who are killed who are not restrained increases with each age group, and that minorities have higher proportions of unrestrained child deaths compared with white children. We also know that misuse is a problem. It's estimated that between 73 and 90% of car seats are misused. Looking at the problem in Maryland and among children and adults, you can see some similar trends. So we have a short video here that talks about the stages of a collision to give you some insight into how crashes work. So just to summarize the video, there really are three collisions in each crash. The first is the vehicle hitting something. It could be another car, it could be a tree, it could be some kind of a barrier. The second is the occupants of the vehicle hitting the parts of the vehicle or hitting each other. And the third is the internal collision, where organs inside your body are hitting other parts, for instance, like your brain hitting your skull. Um, all of this is what contributes to the higher injury and death rate in crashes. Children in particular are more vulnerable to injury because they have the larger, heavier head, higher center of gravity. Their skull is very soft, the plates haven't fused yet. Their hip bones are rounded, and this tends to be something that's more of an issue for older kids, like when you're talking about booster seat ages. But their lap belt will not stay down over their hip bones. It tends to slide up because of the shape of their hip bones. And they have a weak neck and weak abdominal muscles. There are adult safety features in cars that can hurt a child in certain situations, like airbags, for instance. This is particularly the problem if you put a rear-facing child in the front seat where an airbag can deploy right behind that child's head. And that causes massive head and brain injuries, spinal cord injuries, and often death. So children need to be sitting in the back seat. Um, Other airbags in your car shouldn't cause a problem if you are in position and restrained as you're supposed to be. Loose, unused seatbelts can be a problem. Occasionally, kids have wrapped unused seatbelts around their neck, and then the seatbelts have locked up and it can strangle them. Seatbelts worn by children who should be in car seats or boosters because they're small, that can hurt a child because, as I mentioned before about the hip bones, it's not going to stay positioned where it should. So a key message here is that cars are designed to protect adults. Children need car seats and boosters to stay safe in the car. So I've already hinted at this, but the solution to motor vehicle deaths and injuries are car seats. And here's some effectiveness numbers that are a little bit old. I personally feel like these could be higher. I think they might be more protective than this, but these are the numbers we have right now. And seatbelt effectiveness. So you can't always anticipate when you will have a crash. This means everyone must buckle up. Everyone must be restrained in every ride. It doesn't matter if you're just in a parking lot, you need to be buckled up. So car seats specifically prevent injury by spreading the crash forces out, concentrating the forces on the strongest parts of the child's body, allowing the child to ride down the crash, providing protection for the child's head, neck, and spinal column, and keeping the child from being ejected out of the vehicle. Maryland's child passenger safety law. Now, I noted the date on this because there is some legislation under consideration right now in Annapolis, so this can change. But for now, every child under age 8 must ride in an appropriate child safety seat or booster seat. They need to use that child safety seat according to the manufacturer's directions also. And the exemption is if the child is 4'9" or taller, which is a very tall child. That's like the 95th percentile. And this law is a minimum. You can max out each stage. Maryland's occupant protection laws continue in explaining that children ages 8 through 16 have to be buckled up in either a car seat, booster, or seatbelt in every seating position. And then once you hit 16, it's your responsibility for buckling up in all seating positions. Just briefly, I want to mention what nurses can do in their jobs regarding car seats. So there's something called a child passenger safety technician, or CPST, and we are people who have taken a certification class. It's a 4-day class, and we have to pass tests and practice skills tests and things like that to get certified as a CPST. So we may help parents install seats, and we guide parents for how to install seats. We don't do it for them, but we are able to do installation. Nurses or any non-CPST can educate the parents on reading the car seat manuals and labels, and they can help refer them for other resources. They can also help the parents with harnessing, like looking up the information in the manual and then helping them adjust the harnesses and fitting their child into the seat. Nurses can certainly and really should refer them elsewhere for installation help. Parents and caregivers' responsibility is to get a car seat, to bring it into the hospital for discharge or for the car seat tolerance screen, and it is their responsibility to install the seat in vehicles. Just a big reminder, and you know this for lots of other nursing practices, but you never provide guidance or assistance if you're unsure of best practices. You should refer to an expert. So this next part, we're going to start talking about specifics in car seats. And I just wanted to give you briefly an overview of how we think about everything associated with correct car seat use. So we think about what is the appropriate seat, what direction should it be in, where should it be located in the vehicle, installation and issues, and the child properly secured in the seat. As I mentioned, you as non-CPSTs won't be dealing with installation or location in the vehicle, but this is just to give you the big picture of what is involved in correct car seat use. Now I will turn this over to Julie Sejak, who will go into the different steps involved in selecting the appropriate seat.
Hi, so the next step is selecting the appropriate car seat. Rear-facing car seats are what you will mostly see for your children that are going to have car seat challenges. These car seats are for children from birth until they reach that maximum harness weight for that rear-facing position. So these children will be riding rear-facing for at least 2 years. Their heads and necks are best protected in this position. So your caregiver may bring into the hospital either an infant carrier, which is a rear-facing only car seat, or a convertible car seat. And you may also see a combination seat. These seats rear face and forward face, but your convertible car seat remains a harnessed seat. I would ask the parents to bring in the car seat as soon as possible for those babies that might be discharged from the full-term nursery, and for NICU babies, maybe 2 or 3 days prior to discharge. You can tell the parents that they just need to bring in the carrier, that they don't need to bring the base in. All infant carriers have a level indicator right on the labels on the sides, so you don't need the base to get that proper recline. You want to make sure that you read the labels on this side of the car seat. Is it the appropriate car seat for the baby's height and weight? The labels are very clearly marked as to what size baby should be in the car seat. So for instance, this car seat is for babies who weigh between 4 and 30 pounds and who are under 30 inches tall. Children will outgrow these infant carriers by height long before they outgrow them by weight. So when their head gets within an inch of the top of the carrier, it's time for a new car seat. Convertible car seats will fit forward facing or rear facing. So they will have 2 stickers indicating forward facing size and rear facing size. So for this car seat, babies can rear face from 5 pounds to 40 pounds, and then forward face starting at 20 pounds and up to 65 pounds. Again, the child will outgrow that car seat when their head gets within an inch of the top of the car seat. Car seats will also have labels underneath of them that tell you when the car seat was manufactured and what the name of the car seat is and what their model number is. And on a convertible car seat, it's usually on the side or maybe on the back. Next is adjusting the car seat to fit the child. Parents should be encouraged to have read their owner's manual so that they know how to adjust the harness for their car seat. So we want to make adjustments to the car seat so that the car seat fits the child. We're looking at the harness height relative to the child's shoulders, the harness length, is the crotch strap in the proper position and at the right length? Is the harness width at the hips appropriate? And do we need inserts to achieve the appropriate fit? Putting the child in the car seat. Children's height and weight must be appropriate for that car seat, and we talked about checking those labels. Children's bottoms should be all the way to the back, and the infant must be reclined properly so that their head is maintained back so they can keep their airway open. Older children may sit up a little bit more, but those young ones need to be reclined back. And there are either labels or indicators on every seat that tells you where that recline is. We need to be sure that all the appropriate inserts are present. Some car seats have just one or two simple little inserts, and others have fancier inserts, maybe foam inserts that go underneath the padding that support smaller babies. So it is very important for parents to have checked their owner's manual to be sure that they have the appropriate inserts for the size of their infant. If the inserts are not present, parents can reach out to the manufacturer of the car seat and have them purchased again. When a child is rear facing in the car seat, the straps or webbing need to come out of the car seat shell at or just below the child's shoulder. For forward facing children, you want the straps to come out of the shell of this car seat at or just above the child's shoulder. Here's an example of a little person with her harness straps coming out of the shell at the appropriate place. Moving the harness straps to fit the baby. So each car seat may be a little bit different. And so again, we need to refer to the owner's manual for how to adjust the car seat's harness straps. Some car seats have harness straps that we rethread, and other car seats have adjusters that move up and down. You want to be sure that the webbing comes through the fabric of the cushion as well as the car seat shell in the same slot. So for smaller infants, your car seat may have options for different loops to attach the webbing to the splitter plate. So we want to be sure that we have the loops attached to the splitter plate appropriately for baby's size. This is an example of a no-thread harness seat. So this car seat, you would not have to move the straps through the slots in the back, but there's going to be some sort of adjuster to move the headrest up and down, which will ultimately bring the webbing up and down. So we want the webbing to be at the baby's shoulder or just below the baby's shoulder. So you want to slide it into that locked position. This is an example of a no-thread convertible car seat. And again, you will pull the tab at the top and slide the headrest up and down to adjust where the shoulders and the webbing come together. Changing the crotch buckle position. So some car seats have this option to move the crotch buckle closer to the baby. This allows for a tighter fit and less likely that the baby will slump down in the seat. You don't want more than about 4 inches between baby's diaper and the crotch strap. So you will move the crotch strap to the position that's closest to the baby to narrow down that space. Some crotch straps can be sort of doubled back on themselves to shorten them for small babies. Again, this is something that you would have to check the owner's manual for to see if you could shorten down that buckle strap a little bit more and keep it a little closer to the baby. A few seats on the market allow you to adjust the hip straps in and out for baby as they grow. Some require you to move them to the inner position for small baby, and some are optional, and some don't have this adjustment at all. Again, this is a time that you would have to check the owner's manual. The example here is an Even Flow Light Max, which is a car seat that's available for 3-pound babies. So this may be something we would see in the NICU. Once baby is in the car seat and the harness is adjusted to the position, you want to be sure to buckle the baby's crotch strap and harness clip. The harness clip should ultimately be at the baby's armpits. Remember, it's a 5-point restraint. 2 bony hips, 2 bony shoulders, and the sternum. That's where we want this webbing to come in contact with the baby. Once you have baby snapped in, tighten the harness, and we don't want to be able to pinch any additional webbing at the shoulders. So putting baby into the car seat, you want to be sure that baby's bottom is all the way to the back of the car seat and that they're sitting up nice and straight along the angle of the car seat back. Baby goes into the car seat in just their outfit. No bulking clothing, no snowsuits, no buntings in the winter. This is an example of a baby too slumped down and not sitting up tall enough in her seat. Here's an example of, is it too loose? So if we can pinch at the collarbone, then we are too loose. We need to tighten that harness a little bit tighter. You should still be able to slide your fingers underneath the harness plate, but your fingers should slide off the webbing and not be able to pinch it. And there's our little people all nice and snug in their car seats. Remember that the harness clip is parallel with their armpits. And a thin jacket is okay, but nothing thick and bulky. You want to make sure that the harness is snugly holding the baby into the car seat, especially for tiny babies in their car seats. You want to be sure to check and make sure that everything is snug and not too tight. And you may find that if there are harness strap covers, that they will need to come off if allowed by the manufacturer in the car and for tiny babies, because it may push those shoulder straps down too far on their shoulders. Also, be sure to check if baby's chin looks like it's falling to their chest, if the head pillow could be actually removed. Again, look in the owner's manual to see. That may allow the baby's head to tip back and keep their airway opened. In some rare cases, you may find that you can put some rolled up blankets on either side of the baby to give a little extra support when they are in the car seat, as well as a crotch strap roll if there's too much distance between the crotch strap and baby's diaper area. Again, you would have to check your owner's manual to be sure that it's okay to do that. There are a few cases where it is not okay.
And this is Suzanne. I'm going to add here that with new safe sleep guidelines, we recommend that these, if you can add these rolled up blankets alongside, do not put them up alongside the infant's face, because should the baby turn the face into the blanket, that might cause some breathing problems. So they would have to stay down, like at shoulder height or lower.
And not recommended up around the head at all. Again, to remember that baby can outgrow their car seat when their head becomes within an inch of the top of that car seat. So in summary, the best way to help your infant breathe properly anytime they're in the car seat, you want to make sure that the child is positioned properly, that their back is flat, their back is flat against the seat back. The child's bottom is at the lowest part of the seat and all the way to the back, and bending at the hips and not at the waist. The child's head is not tipped forward, so none of that chin to chest thing, and that the recline is according to the manufacturer's indicators. So either a line on the side or a bubble indicator. Remove the head pillows if there is one, if that is an option. Reminder of the role of the staff. Our job is to educate caregivers on the basic message of car seat safety and to assist them in these adjustments. Is the child in the appropriate seat? So is it the right size for the baby? Child is properly harnessed in the seat, so they're snug in the seat. Caregivers need to correctly install the car seat in their vehicle. And we document services provided or declined by the caregiver.
Great. Thank you, Julie. We're going to move on and have a very short exercise to identify the misuse. In this very brief exercise, we're going to identify the misuse in these pictures. So in picture 1, what do you think is happening here? I'll give you just a moment, or you can pause if you need more time. In this picture, the car seat harness straps are above the infant's shoulders where they need to be at the infant's shoulders or below. There also is no chest clip evident in this picture, which could mean it's missing. Maybe it never got put back on after washing the padding, or perhaps it's a European seat where they don't require chest clips. The harness straps may be a bit loose too. And in number 2, those cute little shoulder pads there are not items that came with this car seat. You can see they don't match the seat, which of course is not the problem that they don't match, but they are aftermarket products which the manufacturer has not certified. They also could be so big that they are causing that chest clip to be too low on the child. Number 3, this little guy has a rolled up receiving blanket around his head, which he doesn't need. He's probably has enough head control there for one thing. But the big problem with this is that if, as he tilts his head forward just a little bit, that blanket's going to drop down behind his head, forcing his head to stay forward, which could block his airway. And this sort of thing is not approved by the manufacturer as well. And in number 4, there are a couple things going on here. A big thing is that the harness straps are too high. They're above the child's shoulders instead of at or below. The harness straps are loose. They need to have a lot more tightening going on there. I think he probably doesn't need the head pillow anymore. It's harder to say with that one because of the hood. Also, there are things added to the seat. It looks like he has rolled up receiving blankets alongside of him, which shouldn't be necessary if he were harnessed properly. And the toys and such added on, those can be a hazard if there's a crash and it bangs into him. So I hope you did okay with this misuse exercise. We'll now talk about how to conduct the car seat tolerance screen. Joan Geckel's going to be leading this part of the workshop.
Thank you, Suzanne. I'm going to start with how to conduct the car seat tolerance screen. Don't forget that Natalie Davis also has a companion piece here of a webinar that you need to complete and watch with all the updated information, clinical recommendations that go along with, and the research that goes along with this car seat tolerance screen. The Academy of Pediatrics states that the infants have an increased frequency of oxygen desaturation episodes of apnea bradycardia while they're sitting in their car seats. Therefore, they recommend that hospitals all develop a protocol to include some kind of observation of a car seat before the discharge of anyone that's born before 37 weeks gestation. And we'll go through some of the different recommendations here. It's called the car seat tolerance screen. Some hospitals call it the car seat tolerance test, but they're interchangeable. In this regard, for this webinar, we're going to call it the car seat tolerance screen. All hospitals should have a hospital policy and guidelines for administering the test. And it should be in either your procedures or your policy. We at my hospital have a policy that refers to our procedure, which is in Lippincott. Ours is a little bit adapted for our hospital. So look in yours to see, or talk to someone at your hospital if you're not sure where that is. Also, this flow sheet is available. It's a great resource. I use it all the time at our hospital. It's best practice flow sheet for car seat tolerance screens, and it really does give you the algorithm of what to follow. You can get a copy from MIMS, and the address, of course, is right here. Who should receive the car seat tolerance screens? Any infants that are born before 37 weeks gestation, those who are at risk of impaired oxygenation when placed in the car seat in a reclined seating position, any with respiratory issues requiring home oxygen, or have airway malformations. At my hospital, we have a lot of tracheostomy patients, so any child that's going home with a brand new tracheostomy will have to have a test no matter what size they are. With hypotonia or neurologic issues, those trisomy 21s, those Prader-Willis that seem a little bit more flaccid, that they have the hypotonia, those, hypotonia, those are the ones that we really also do. And with cyanotic heart disease, no matter what size or age they are. Also consider testing full-term infants that are born before 2.5 kilos, especially those who have any other risk factors. We automatically look at all these things when we do our car seat tolerance screens, and it's written in our algorithms. Prepare the family for the car seat tolerance screens. So explain on what it is at this non-invasive test. We talk about it at admission when they're coming to our hospital. For you all, of course, it's usually at a NICU or something like that. So just give them a heads up to get the car seat, what size to bring in, especially if they're a 4-pounder, to make sure they look for the smaller car seats. And usually we tell them when the NG tube's about to come out or they're taking most of their bottles, that's a good time to bring in the car seat. And schedule the test depending on how your hospital sets it up. And the caregivers are invited to participate if possible. They don't have to be there, but we do try to explain them and have them do the hands-on part of just putting the baby in at a different time if they weren't there for the car seat tolerance screen. Also, like I was saying before, remember to check the car seat for appropriateness. So this is something to educate the family before they bring it in. Does it meet the weight, height, and age limits for the child? We don't want them to bring in a huge forward-facing or something like that, or difference one that's too big for the baby in that they don't meet the size requirements. If they're a 3.5-pound baby, you don't want to be putting them in a 5-pound starting car seat, though some 4-pounders will do actually have a 3-pound limit and not the 4-pound as it states. Also, you're going to look to see if it's in good condition, there's no missing parts, if the seat is not recalled or expired. And this is where you would look for it on the side of the car seat. Most of them will have it in their manuals if they did bring the manual in, which we asked them to do. But also on the side of the car seat, they usually do have the size of where this would start. So here, this car seat tells you right now 4 pounds to 30 pounds and whose height is less than 30 inches. The timing of the test. Any infant for those in newborn nurseries that's greater than 24 hours of life. You really want to give them that time to recuperate from birth. For those that are in NICUs or any other kind of newborn nursery that has a baby that's going to be there for a while, you want to do it several days to 1 day prior to discharge. You don't want to do it the same day if you can help it because you're already putting that baby in a car seat. And you don't want to put them back in after stressing them with the car seat test. Again, the infant does not use an NG tube, and the infant can maintain a stable temperature in an open crib. So a baby who is out of the isolette at least 24 hours, we tell people, because you're still looking for the temperature, looking for their instability. The NG tube's out, they're taking all their bottles, and then usually 30 minutes of a feed. So when the feeding stops, about 30 minutes later, because that's what's going to happen in real life. Moms are going to feed, they're going to put the baby to go out. Before they leave, they're going to put the baby in the car seat. So we want to kind of test real life situations. You're going to then recline the car seat to appropriateness for the car seat tolerance test. Again, as we have talked before, tell the parents to leave. They do not need to bring in the base. They just need to bring in the car seat itself. Have them put the base in the car so it's ready for the baby. And they don't fit well on the floor, and they don't give the correct position if you're using that base on the floor. So look for there's different kind of recline indicators on the car seat properly. And you'll have to look to see what type your car seat has. And here's some pictures of the different types. Sometimes to get that line, you're going to have to put a rolled up towel or sheet or something underneath the back part of it, so that you can get the correct line. It doesn't usually take much. It takes a small roll, if any time, for most of them. And don't forget to secure the baby in the car seat correctly. I guess we had talked about it earlier, but again, this is a great picture. You want to start at the hips and then move your way up, getting rid of most of the slack ahead of time before you clip the clip in the middle, and then you tighten it up. Again, the pinch test, as we all know, to make it snug, any kind of pinch that is, you can get any kind of webbing, then you're too loose. You want that up nice. This one's nice and snug. This in the middle. That's perfect. It's not cutting into the kid's skin, pushing them down. It just falls nicely on their shoulder, but it's not as loose as the other one. And the chest clip is right at the armpits where it needs to be. This baby looks really nice. It's secure, and it looks content with good head positioning. Best ways to help the infant breathe properly in the car seat. Make sure the child is positioned properly. Make sure when you put the baby in, put that back flat against the seat and kind of slide them into the bottom, is the lowest part of the seat, bending at the hips, not the waist. If you kind of tuck that baby in, sometimes they'll have those hips bent there, versus if you kind of hold the baby and just kind of slide them in from their back all the way down, pushing those hips making sure those hips are all the way back. And make sure that head is not tipped forward, no chin on the chest. Make sure it's, then you have that nice positioning and straight back. And then, of course, recline the seat according to the manufacturer's indicators. And remove the head pillow if there is one, and if its use is optional. So just kind of look at that to see how they fit. That would probably be one of the biggest things I have issues with. Equipment for the car seat tolerance screen. Again, most hospitals now have a monitor, have this nice car seat setting so that you can actually do your test on here and records all the different events that happens. So set it to the time, usually an hour and a half, 90 minutes, up to 2 hours or 120 minutes, or the length of the car. We do actually ask them to stop at 2 hours, just because those babies are not used to sitting at that angle, and the stress on the joints, as well as your pressure sores from sitting in that position, is very exhausting for that baby and can cause redness and that tender skin. And our new cars today tell us at 2 hours that you should stop. My car beeped at me on the way home from Florida saying I've been in the car for 2 hours and should stop. So that's a good thing for all of us. Putting on the cardiopulmonary leads. Again, the respiratory is the upper right chest, the heart is up the upper left, and then the ground is the lower left quadrant of the abdomen. The biggest thing with this is, if your child's always on leads, make sure they're nice and in the correct position. I think that's one of the biggest errors that we find, is that the baby's had them on for a couple of days and they've slid, and so they're not really good connection. And sometimes you'll have false low heart rates from that. And then placing the pulse oximeter on the foot or the hand. Another thing, again, that's the same thing. Make sure your wire is a new one, or it's got the stickies, it's nice and sticky and it fits well, and it's not, the wires haven't been bent so many times that it's just not picking up correctly. If the baby has a tendency to be cool, especially your cardiac babies, making sure they have some socks on their feet or something like that, so they have good circulation to those areas, picking up the pulse ox correctly. Oh, and this one is a special car seat for all emphaseals. FYI, since it does look different than the ones that we usually see in hospital. So this baby is getting ready for the car seat tolerance screen. She's in her car seat. She looks good. Her monitor's going. She's got good sats, heart rate, respirations look pretty good too. So you can see it's counting it down on the right-hand side screen. So she has 23 minutes left in this car seat tolerance screen. Suggested pass-fail criteria, apnea greater than or equal to 20 seconds. Again, knowing that if the baby does change breathing pattern, It may say it's a apneic episode. So if you're not observing, kind of looking at that baby, keeping an eye on them. Heart rate less than 80 beats per minute for greater than 10 seconds. Desaturations of greater than 90 for greater than 10 seconds. Respiratory distress that did not improve with proper positioning. So again, that would be the baby who's just breathing so fast it's above their normal. I mean, some babies do breathe at 60 and 70, but if this is not their normal, and they look like they're really working hard and they look uncomfortable, maybe their heart rate's a little bit higher than normal also, because they are uncomfortable. Those are kind of things to make sure to keep an eye out and be a fail. Frequent episodes of periodic breathing with brief to borderline desaturations is concerning and should be discussed with the attending physician. Again, they're still having periodic breathing, and their desats are just, right at the point, and, maybe 1 or 2 seconds here and there. Those are kind of things just to keep an eye out for and to really talk over with the doctor about. All right, and then documentation of the car seat tolerance screen. Each hospital has their own way of documenting. Some people may still use paper. I know in our medical record, we use Expanse, and we have ours written out, and everything is in there that we document ours in. So follow again your policy and your protocol on how to document. But what usually, of course, is when you start. Your vital signs at the very beginning before you take that baby and put him in the car seat, and then of course, what your hospital says, and then of course letting the doctor know if they passed or they failed. Definitely, if they failed, you need to notify the physician, and then of course talking this over with your parents too, and letting them know and making them understand what it was and how the baby did, because they're usually interested if they're not there at night or daytime when you do it. Again, this baby passed. Yay. I always love seeing those. So again, if any infants meet any of the fail criteria, again, on this algorithm, it'll show you right what to do the next steps. So usually if they do fail, you're going to wait and make sure that it was positioned properly, but give them that at least a 12 to 24 hour. And if you can have the luxury of 24 hours, I suggest it. But at least 12 hours, because that really is tiring for this babies. They're not used to being in that position. So you want to give them time to recover. If they had the head insert in there, make sure, of course, to remove that. That might be something. One thing I have found, I've been a car seat tech now for several years, and as working with the neonatal population for many, many years. It was the head positioners a lot of the time, or the straps that are at the shoulders sometimes are just when they sit in there for a length of time, they actually slump a little bit and it becomes above. And I find those are the children that may have their head go forward a little easier. And sometimes it would be dropping it if they have another slot a little bit lower, to try doing that. But usually the head positioner is the head insert is the main thing, if it can be removed, to do so. And then, of course, repeat to let the doctor know. At our hospital, we let our car seat specialist, car seat child specialist, look at the car seat and refit the baby and start the car seat. At your hospital, you may have 2 fails before you do that. So whatever your policy says, but you really should, if they fail twice, you really should be seeking out somebody who has more information and more expertise in this area. And then again, maybe talking to the doctor about, pediatric pulmonologist or sleep studies, what we do. If the child's failed twice, we really look at to see how the pulmonologist look. Sometimes we have the cardiologist look at them too to see if there's something we missed, some pulmonary hypertension or something else like that we have missed. If you're in a newborn nursery, then you would probably have them stay in a NICU for a while and to do the sleep study. And then you would again, depending on the recommendations, you could repeat the car seat one more time or several, whatever. Give them some time to rest. Sometimes they're immature and they just need those extra few days. Maybe they're still having a few brief desats here and there. So just keeping an eye on them and giving those a few days to mature, that's what usually is what they need, and then they usually do pass. If they have severe reflux, sometimes that may be it too, so getting that reflux under control sometimes is helpful. If you're going to go the route of the car seat, the car bed, you're going to have to definitely consult then um, a child passenger safety tech um, and talk to them about the car bed. If that's the case, you'll have to order that from somebody, usually MIMS or KISS.org. They can get you that car bed, but they have to do the education. You still have to do another car bed trial too, just as you did the car seat tolerance screen. It's going to be a car bed screen for the 90 minutes or hour and 20 or whatever time that you have decided on. And not all babies can even tolerate that on their back for that length of time. Also consider going home with a monitor and oxygen, because usually if they need that, there's something else going on. And that's what we have found, is the baby has had some pulmonary issues in the past, was on oxygen for a long time. They've come off and they're tolerating okay for little things, but when they get stressed, we find that that's when they'll desat. So they'll go home on a little bit of oxygen, and that usually solves the problem. But they should, if they come off the oxygen again, that should be talked over with the physician. So if they're go home on oxygen, really consider when they talking to the home pediatrician that they really should probably have a car seat tolerance screen when they do come off that oxygen. Usually they're followed, of course, by a pulmonologist, and they can also order that for them, because you don't know how they're going to tolerate once they do come off. So for a case study that happened, after being called from a full-term, baby was failed a car seat test multiple times. The nurse, who's also a CPST, observed the baby sitting in the car seat. She reported that she was not impressed with the look of the baby. The baby was seated and harnessed properly. The baby just didn't look right. The nurse requested an NICU consult and more tests to rule out infection. A sleep study showed that obstructive apnea. The baby was desaturated to 70 the day before discharge, the day before. So the baby then had additional 5-day stay for observation and went home on oxygen. And that's happened to us a few times when they'll start doing that. When you're stressing them out, they'll have a big desat, and then usually they'll do either a sleep study, they'll start showing some other things, and they will put them on oxygen and just kind of watching them for another 5 days or so, and then they usually do pass the car seat test. And it's true, if they fail a car seat test, there is usually a reason, so listen to the babies. Thanks again for listening to me, and hope this was helpful to you. Have a great day.
Thank you, Joan, for that presentation. A reminder, if you are doing the April 26th in-person workshop, you want to also listen to the online lecture on the car seat tolerance screen and the research and all of that that's by Dr. Davis. For this workshop, if you would like to get the contact hours, you need to answer the short quiz on this lecture and send the quiz back. And if you get 80% correct, we will grant you the continuing education credit for this lecture, and we'll send that your credit confirmation later on. If you have any questions about this presentation or about anything related to child passenger safety, please contact me, Suzanne Ogaitis Jones, at cps@mims.org, or you can call me at 410-706-8647. Thank you so much.